Hello, everyone. Good afternoon and a warm welcome to this webinar on what is cardio-renal metabolic disease. So my name is Steve Wheatcroft. I'm a professor of cardiometabolic medicine at the University of Leeds and a cardiologist at Leeds Teaching Hospitals Trust. And it's a pleasure to introduce my co-presenter, Hannah Beba, who's a consultant pharmacist in diabetes for West Yorkshire and Leeds Health and Care Partnership. So Hannah, you might have to take me to the next slide, I'm afraid. Yeah. So this session is being recorded, and we're going to start with a couple of disclosure slides. So these are Hannah's disclosures, and we'll leave those up for a few seconds for everyone to read. And then we'll move on to my disclosure side, which is listed here. Thanks, Hannah. And so I'll kick off with the presentation, and then Hannah's going to join in a few slides' time. So during this webinar, we're going to discuss what constitutes cardio-renal metabolic disease, and there's a lot of discussion, a lot of noise about this area nationally and internationally. So we're going to talk about what CRM disease is, how we approach prevention, how we identify those most at risk, and how we manage cardio-renal metabolic disease in a day-to-day practice. And we're going to do that through a collection of case studies to employ or explore the complexity in management and how we can decide on impactful interventions. Next slide, please, Hannah. So in terms of what is cardio-renal metabolic disease, then there are a variety of definitions, but I think in the sort of simplest term, it is the combination of cardiovascular disease, chronic kidney disease, and metabolic diseases, including obesity and diabetes. And the reason that this is an entity is that these conditions share underlying pathology. So the mechanisms that contribute to these three conditions are shared. And we can see in the center there multiple biochemical and physiological dysregulations, including insulin resistance, sympathetic nervous system activation, dyslipidemia, inflammation, endothelial dysfunction. So these underlying pathologies drive all of these three conditions. And the other thing is that the ways of treating these three conditions are often similar as well. So we can think of patients holistically. Not all patients necessarily have to have all these conditions at the same time, and we recognize that having one of these conditions increases the risk of developing the two other components of cardio-renal metabolic disease over time. And the other thing to say is that there are other facets of cardiometabolic disease that we're not going to cover in great detail today. For example, metabolic liver disease, which is an important component of this condition. Next slide, Hannah. So the reason that cardio-renal metabolic disease is important is that these conditions conspire together to increase the risk of health problems and ultimately increase the risk of mortality. And this slide shows for an example of how diabetes and chronic kidney disease can conspire together to increase the risk of cardiovascular diseases such as heart failure and myocardial infarction, but also increase the risk of progression to renal replacement therapy and all-cause mortality. And it's important to note when we think about diabetes and CKD in particular, that patients with these conditions don't usually die from the underlying disease, but they die from the cardiovascular complications associated with diabetes and CKD. So this is why it's really important to tackle these patients holistically and think about their cardiovascular risk and how we can improve that. Next slide, please. So Hannah, this is over to you.
Thanks, Steve. So I think, one of the things that we need to consider is what does cardio-renal metabolic disease look like across somebody's lifespan? And actually, it can be really different at different stages. We obviously have people developing some things in childhood, puberty, pregnancy, menopause, in that older age. And so it's not just a one trick thing. We have to really be thinking about this at lots of different touch points with our people living with this sort of complexity and multimorbidity, and so hopefully some of the case studies today will kind of speak to that, and we'll take you forward through that. There are lots of different stakeholders in the arena of cardio-renal metabolic, and one of the things that we've done in Leeds, which has been really helpful, is to meet one another and to join together to do some of this work, regularly. So what we really want to try to do is bring together primary care teams, GPs with specialist interests, also long-term condition leads, commissioners, our medicines optimization pharmacists, our primary care network pharmacists. There, we're starting to see now specialist posts in particular disease areas within this group of disease management popping up now into our primary care networks. And we're looking also to bring together our specialists in areas, cardiology, diabetes, our lipidologists, our renal medicine specialists, and our weight management services as well. And it's not until we start having these collective discussions that you really start to understand the complexity and the number of things that need to come together actually to even deliver just one particular pathway. So we've just all worked together through this forum to try and get the West Yorkshire renal CKD guidelines out there, and it's been a real job of work to get everybody's thoughts into something that's a succinct and sensible pathway for somebody living with this multiple disease states to navigate, because at the end of the day we come up with our siloed plans, don't we, sometimes, and when you put it together it's so convoluted for the person living with these diseases that even they don't want to engage with it. And that's really the key, is actually getting the person living with the complexity to want to engage in the system of care that we've designed that are supposed to help them. And one of the things that we've started to think about in general in Leeds and beyond is around this kind of 4-tier model of care. You'll have seen it a few times in Leeds now if you're from the area. We've done some work in diabetes around this 4-tier model of care. We've done some work that Steve's been involved in around heart failure as well. And really what it's about is producing almost a bit of jam in your sandwich. So doing that basic care well at tier 1, making sure that we're doing lipids well and blood pressure well, and those things that are really the bread and butter of primary care. And then at tier 2, starting now to think about how do we augment what we do in the primary care networks. Maybe this might be offering PCSK9 therapy, for example, in the future. It might be around higher spec technology for people with diabetes. It might be slightly more reach drugs around renal care, such as finerenone, for example. So it might be building in some slightly more in-depth knowledge within that primary care network team. And then also we need to think about how do we bring that expertise out of the ivory tower and start doing that interface work a lot more effectively. So that integrated care where we start really thinking of ourselves not as secondary care providers and primary care over here, but actually as a system of care, because that's what people living with cardio-renal metabolic are actually navigating. So we should be doing the same. So case study, over to you, Steve.
Thanks, Hannah. So we'll illustrate the management of cardio-renal metabolic disease through the case study. So this is the first lady. She's a 39-year-old woman, recently diagnosed with type 2 diabetes and has been initiated on treatment with metformin. She is, a relatively typical patient we might see in day-to-day practice. So her BMI is 34. She's had her Q risk score calculated. You can see on the right there, coming out at 11.2%. She's of Pakistani origin. She used to smoke, has migraines, moderate depression, which is on treatment with mirtazapine. She's unemployed and lives in an area of high socioeconomic deprivation, which is important. We'll come on to that. Luckily, currently, her kidney function is good. Blood pressure in clinic was elevated, 150/92. And you can see there her lipid profile at baseline with an LDL cholesterol of 4.5 and triglycerides of 5.5. So not ideal. And, we need to pick up on the factors of HADIL and what we can do to improve her long-term outcome. So she is someone who, you know, will be at future risk of cardiovascular disease and CKD if we don't act and reduce the risk of those conditions. And there is mounting evidence now that we need to be looking more at lifetime risk rather than short-term risk that we see from the risk calculators, and bear that in mind. So next slide. So the first thing we'll think about is blood pressure, and we have the nice treatment pathway, which is on the slide here. So I suppose at the moment we know that she's got an elevated clinic blood pressure. We don't really know anything more about this, and we know that she has risk factors for hypertension, including the BMI being in the obese range. So it's important that blood pressure is further assessed, and the way of doing that in this patient would be to think about home blood pressure monitoring or ambulatory blood pressure monitoring, and look to see whether her blood pressure on average is above the threshold of 135/85. So if it's below that threshold, then she can be kept under periodic review, but it's quite likely, looking at the presentation profile, that her blood pressure will be in the range showed in the middle here, between 135/85 and 150/95 or below. And this is the kind of level at which we would want to talk about blood pressure, maybe starting with lifestyle advice before considering drug treatment, but have a low threshold for thinking about drug treatment in terms of having an eye on her lifetime risk of cardiovascular disease. The other thing to mention is, because she is under the age of 40, then NICE does recommend considering specialist evaluation for secondary causes of hypertension. And this is something that should be borne in mind in terms of identifying those people who have potentially treatable causes of high blood pressure when they present under the age of 40. Next slide. So we move on to, we'll come back to blood pressure in a second. We'll then think about her lipid profile. And in this lady, she's under the age of 84 and she has type 2 diabetes. So she fits into a category where we would look at using Q risk, at least to give an initial indication. And this predicts her risk of cardiovascular events over the next 10 years. And with the Q risk being over 10%, then that puts her into an increased risk factor group. So we would want to look at this holistically and look at whether there are modifiable risk factors that could be addressed, and we'll come on to this. And then we'll come on to a discussion about whether primary prevention therapy for lipid lowering should be initiated. And that would usually be with atorvastatin 20 milligrams daily. We need to bear in mind, however, that this patient is a woman of childbearing age, and there would need to be a discussion about whether she is planning pregnancy or has the potential to become pregnant before discussing lipid lowering therapy, and particularly statins. Next slide, Hannah. So we saw there that the level of triglycerides was moderately elevated in this patient, and I think triglycerides are one of those factors of lipid profile that sometimes causes a little bit of confusion and misunderstanding. Now, we will come on a little bit later in the presentation to targeted therapies for raised triglycerides that can reduce cardiovascular risk. But in broad terms, we're really looking about whether the triglycerides are in a level where they might predispose to pancreatitis. And that's really looking at fasting triglycerides of 10 to 20 millimoles per litre or higher. It is important to think about getting a fasting level performed because there is significant rise in triglyceride levels postprandially. And the other consideration is whether there are secondary causes that are contributing to hypertriglyceridemia. And we'll come on to that in another slide. For most patients with moderately elevated triglycerides, the triglycerides will be lowered to some extent by statin therapy. And that tends to be the commonest scenario we encounter here. Next slide, please. So statins do reduce triglyceride levels, usually between 10 and 20% from baseline. Mechanisms are not fully understood, but we know that the higher intensity statins, particularly atorvastatin and rosuvastatin, are most effective. So most patients with raised triglyceride levels qualify for lipid-lowering therapy with statins anyway, based on their Q-risk score and LDL cholesterol levels. Next slide. So we talked about social deprivation maybe impacting on Hadil's risk of future cardiorenal metabolic progression and events. And this slide just illustrates this quite nicely. So if we look, for example, at the middle panel here, this is cardiovascular disease mortality, and this is stratified from left to right, depending on the socioeconomic deprivation quintile, with the most deprived being over on the right. And we can see in the bars here that this is the impact of lifestyle on cardiovascular mortality in each range of socioeconomic deprivation. And I think the two take-home messages here, we can see that lifestyle factors do impact upon cardiovascular mortality risk, but that effect of lifestyle change is exaggerated in the most deprived socioeconomic quintiles. So we can see that this additive effect between lifestyle and socioeconomic deprivation, and pointing out that even if patients in a socioeconomically deprived background do make lifestyle changes, they remain at a higher risk than patients in a lower area of socioeconomic deprivation. And we can use this really to target our interventions to those in the highest risk groups. Next slide, Hannah. So triglycerides, the things to think about really if we see someone with an elevated random triglyceride level is, could it be that the patient was in a postprandial state and really a fasting sample would be advantageous? And then we think about what could be driving up triglyceride levels. And the commonest things are increased alcohol consumption and type 2 diabetes. So those are two things really to drill down on. And often controlling glycemia in the context of type 2 diabetes will have a large impact on hypertriglyceridemia, as will moderating alcohol consumption in those who drink more than the recommended amounts. And over above that, there are some medications that can increase the risk of hypertriglyceridemia. And we know that making changes to diet and physical exercise can help to reduce triglyceride levels. Next slide, please. So what can we advise in terms of hypertension management? So this is, the first time that Hadil has been diagnosed with hypertension based on ambulatory blood pressure monitoring. So it's not unreasonable to start with lifestyle recommendations. And we know that even modest levels of physical activity, such as walking for 30 to 45 minutes a day, can improve blood pressure control. And we know that regular exercise can provide additional control to blood pressure lowering medications. Weight loss is really important. So 1 kilogram weight loss can reduce blood pressure by approximately 1 millimeter of mercury. And it's increasingly recognized that sleep apnea can have a major impact on hypertension, and often blood pressure control in people with somewhat difficult to control blood pressure can be revolutionized by tackling sleep apnea. Next slide. So back to you, Hannah.
So obviously Hadil is in the obese category, and one of the things that I just wanted to mention is actually the importance of how we speak about obesity. There's a lot of stigma around obesity, and therefore we sometimes struggle to have meaningful consultations around this in order to try to affect any change. People feel very stigmatized in society in general, and therefore it can be really difficult to tackle this major condition that actually, in fact, it's not even sometimes recognised as a condition, and that's part of the problem as well. So I think that something there around that language does really matter in obesity, and I would really recommend that you read this document. It's kind of off the back of a document that was Language Matters in Diabetes, which was another area where we really needed to think about how we have consultations and how we affect change in a population. And obesity is connected to lots of different things. So obviously there's weight-related stigma, which can lead to prejudice about disability, discrimination and rejection, but also victimization. And then this feeds into this low esteem due to having this body image problems. And then you get anxiety, you can get binge eating or disordered eating off the back of that, and depression and physical inactivity, which then leads into the sustained obesity, or even a worsening of obesity as it goes forward. So you can see it's very complex and has links, which is why often in weight management services, really the psychological input and the psychology part of delivering some of these programs is actually really important and almost essential, actually, alongside of some of our medical input. Lots of different classes of obesity. So Hadil sits in this obesity class 2, if I remember now what BMI she was, and this is because she's South Asian, and so this obesity develops at lower BMI. So again, we need to be thinking about that, because some of the medications require us to know that in South Asians they'll get access to some of the weight loss drugs and also some of the diabetes drugs at lower BMIs, and you don't want to really restrict access, so we need to understand that. And like I say, obesity really remains untreated for all sorts of different reasons. A, people don't seek the help. B, we don't have services that are set up to receive referrals at the moment. Our tier 3 weight services are a mess across the country, not just here, but in general. And so you can see here, this was a study done in 2016, and I can't imagine this has got any better. It's probably got worse with post-COVID. But you can see here, this obesity shows the number of people indicated. It's a US study, actually. Number of people who would be indicated for pharmacotherapy, and actually only around 2% of adults received pharmacotherapy, whereas with type 2 diabetes, a recognised condition, 86% are receiving some sort of therapy for that. So again, is it about the fact that we recognise some conditions and we don't with others? Also around the stigma and the access, we need to think differently on this and quickly, because it's an epidemic that's going to really put enormous, if not insurmountable, pressure on our healthcare systems as we move forward. And this really speaks to kind of that holistic, person-centered approach. This is about diabetes from the European Association of Diabetes, their guidelines. But I think it's a really nice way of thinking about the components of care that we need to be putting in when we're thinking about type 2 diabetes management in particular, with our goals of care being to try to prevent complications and to optimize quality of life. And there are lots of different things that go on around that. But we think of it as sort of 4 quartiles of action around medication for glycemic management, weight management, cardiovascular risk management, and then thinking about that cardio-renal protection in everything that we do. So in our glucose lowering medications and beyond. And this is just kind of a blown up version of that. Have I taken your slides now, Steve? I've just thought I'm just pressing on with this. No, it's still me. That's fine. So the type 2 diabetes guidelines here. So you can see that this is split into kind of two things that we need to think about. So our first goal is the cardio-renal risk reduction, and particularly around high risk patients. And Hadil would definitely be a high risk patient, because really what we're qualifying as high risk is anybody with that Q risk of over 10%. And we can divide that into people who have atherosclerotic cardiovascular disease, heart failure, or already have developed CKD, or if they've got other indicators of high risk, or a collective of high risk conditions. And here you can see that Hadil would be high risk. Also, she's obese and she's got hypertension. We don't know whether she's a smoker. I can't remember whether we knew that or not, but anyway, she already qualifies under this. So really we need to be out the door leading with metformin and an SGLT2 with proven cardiovascular benefit, which is pretty much all of them that we would use regularly. So in our guidelines, it would be dapagliflozin or empagliflozin. And then we're starting to add in beyond this. This is a European guideline, so they have more money than we do in the NHS. So we do still say to use SGLT2s first, and then GLP-1s a bit further down the line because they're more expensive. And then goals also in around achievement of weight management goals. So we need to be asking people what is their weight management goals that they have and trying to help them achieve that. So some of that might be achieved through not adding medications that add weight, for example, consideration for weight loss therapy, including metabolic surgery for some people, not for Hadil in this case. She wouldn't reach the thresholds, but also, so it might be just preventing adding weight, or it might be actively trying to help somebody lose weight as well. And so it's starting to think a lot more now about precision medicine. So if you've got a subtype of person, so often guidelines are written with one person in mind, or very limited sort of spectrum. And we know, I think one of the struggles with cardio-renal metabolic care is the fact that there are lots of different subtypes of people. And so wouldn't it be great if we could put in somebody's various different characteristics, and, you know, an algorithm or AI system would be able to tell us what the optimal drug treatment for that person would be. And these are just a few examples of how that might work. So for sulfonylureas and thiazolidinediones, of which we only have pioglitazone now that we use, females with obesity are actually likely to have greater glucose lowering with pioglitazone than sulfonylureas, which we might expect because they're sensitizing. But males without obesity are likely to have a greater glucose lowering with sulfonylureas. DPP4s and GLP-1 antagonists, if you've got markers of higher insulin resistance, which are associated with a lesser response with DPP4s, but there's no evidence of an association for GLP-1s, which is interesting because they're working on the same pathways. Again, GLP-1 receptors, if there are clinical markers of lower beta cell function associated with reduced glycemic response to GLP-1 therapy, you might imagine that. So if you put all of these things that we've found through the plethora of research that's been done into something which would be able to consider all these different angles that we could take and all the different combinations of drugs that we might use, we might actually be able to tailor therapy a lot better to people. We try to do that ourselves, but sometimes when you're trying to keep on top of all the things that are changing with diabetes, renal, cardiology, medicines, it's very difficult to keep abreast of all these things all the time, and it's the real challenge of the primary care clinician. And the direct study, so for Hadil, if she's only been diagnosed with diabetes within the last 6 months, then 6 years, she may be eligible to go into the remission program, which again is a very low calorie diet, 800 calories a day for a 3-month window, and then reintroduction of a normal diet thereafter. And this 15 kilo, or on average 15 kilo weight loss, achieves a massive amount of remission, and it basically defatifies your organs. So all that ectopic fat that sits around the organs causing that insulin resistance, that's the real cornerstone of type 2 diabetes, is gone. And most people will stop all their glucose lowering medicines. And for her as well, you would probably put her hypertension into check, and it would help with her lipids as well. So through one intervention, we've actually managed to achieve all our therapeutic goals for that person. And back onto you, Steve. Thank you.
Thanks, Hannah. So the one thing I forgot to mention at the beginning of the webinar is that we're very happy to take questions. And so feel free to put any questions in the chat as we're going along, and we can address those perhaps at the end of this case study, Hannah. So let's move on to James. So again, this is a patient that, you know, is a typical patient of mine. So he's a 65-year-old man. He's had a past history of myocardial infarction. He also has depression and CKD stage 3 and has type 2 diabetes. So a very typical patient with multiple medical conditions affecting cardio-renal metabolic disease. So let's think about his long-term risks, you can see the medications over there. So he's actually reasonably well treated in terms of the agents we have available, with metformin for diabetes, glucose lowering, dapagliflozin for its multiple effects in terms of diabetes, cardiovascular disease and kidney disease. We'll discuss some of that. He's on ramipril and bisoprolol following his heart attack. And as we'll see, he's not tolerated statins in the past and is currently receiving treatment with ezetimibe. So some of his numbers are on the screen here. So LDL cholesterol of 4.5, certainly not ideal. And in terms of targets to treat to, you may well be aware that NICE recently updated its secondary prevention target for LDL cholesterol in December last year to a value of 2.0 millimoles per litre, which is slightly higher than the previous LDL cholesterol target of 1.8 we were working to. And we know that organisations such as the European Society of Cardiology have got more stringent LDL targets for secondary prevention of 1.4 millimoles per litre. So he's certainly nowhere near target on either of those levels. Triglycerides, again, are mild to moderately elevated at 3.5 millimoles per litre. Blood pressure readings in clinic are actually looking quite respectable. And we can see that his glycemic control is pretty good with an HbA1c of 52, but he has CKD with an EGFR of 39 and a UACR of 5.5. So we're going to focus in James's case at talking about lipid management and CKD management. And I'll kick off by talking about lipid management for James. So if we have the next slide, Hannah, please. So the first thing to say is that I think whichever pathway you look at, this is a secondary prevention type patient. So the Q-risk score is no longer relevant. He's got established atherosclerotic cardiovascular disease and other risk factors, including type 2 diabetes and CKD. So he would be considered to be at very high risk. And he fits the European Society of Cardiology guidelines criteria for being at very high risk of future cardiovascular disease. Next slide, please. So in terms of lipid management, again, this is a common scenario. I think we all see patients like this virtually every day where they previously tried statins, they're labeled as being statin intolerant. And I think the first question is, well, are they really statin intolerant? And what have they tried? And what were the side effects that led them to discontinuing statins? And then the second thing is, what are we doing, assuming they are truly statin intolerant, in terms of managing their dyslipidemia? And, you know, there are things we can do, and we have ezetimibe, for example, and we have ezetimibe together with bempedoic acid, both underused. And I think it's worth a couple of minutes just discussing the role of ezetimibe, and particularly ezetimibe with bempedoic acid, in the management of dyslipidemia. We mustn't forget, however, that there are also non-oral therapies for lipid lowering. And again, these are dramatically underutilized. So we have PCSK9 inhibitors available for this setting with the monoclonal antibodies, which patients may be elevated or may be eligible for if their LDL cholesterol is above 4 millimoles per litre or above 3.5 millimoles per litre if they've had more than one cardiovascular event. And there's inclisiran injectable therapy, which it can be prescribed if the patient's LDL cholesterol is 2.6 millimoles per litre or higher. So James would be eligible for both of those injectable therapies as well. Next slide, Hannah. So just a brief overview of bempedoic acid. So again, this is somewhat underutilized, but it is a very useful tool, particularly for patients who've struggled to tolerate statins. It acts upstream of statins, so it works on the cholesterol synthesis pathway within the liver, and it can work in conjunction with statin therapy. It's not active in skeletal muscle, so this is one of the benefits, is although it inhibits cholesterol synthesis, unlike statins, which also inhibit cholesterol synthesis in muscle, bempedoic acid does not. The NICE TA says that it is used or should be used together with ezetimibe in patients where statins have not been tolerated or contraindicated, although you'll see from the license that it is licensed to be used in combination with statins. Next slide, please, Hannah. So why can bempedoic acid be useful? We're not going to go through these slides in great detail, but we know that it works. So these are data from the Clear Harmony study, which showed that treating patients with bempedoic acid led to a significant and sustained fall in LDL cholesterol, as you can see in the top left there. And on the next slide, we'll see that there are clinical data available from the Clear Outcome study. So this was a randomized controlled trial in patients with CVD or high risk of CVD, and it looked at the composite outcome of major cardiovascular events, which was defined as death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, or coronary revascularization procedures. And you can see over on the right there that it showed superiority with a hazard ratio of 0.87 and a significant reduction in major adverse cardiovascular events. So we know that it's effective and it works, and it's certainly something to consider in patients who cannot tolerate statins. Next slide, Hannah. I'll point you towards this pathway from the Accelerated Access Collaborative. So this is easily accessible online, and if you just Google Accelerated Access Collaborative statin intolerance, this will pop up. Again, this is underutilized. It gives us a strategy to manage statin intolerance, and it comes back to the question really to discuss that: is the patient truly statin intolerant? Are they having typical symptoms of statin-related muscle dysfunction, which is symmetrical pain, so bilateral pain and weakness in the large proximal muscle groups, which gets worse with physical activities? And if they have that kind of potential side effect, we should check their creatine kinase levels and act accordingly. And if the CK levels are between 4 and 10 times the upper limit of normal, then it is worth pausing statin therapy for 4 to 6 weeks and then re-challenging, perhaps with a different statin at lower dose, using a high intensity statin such as atorvastatin 10 to 20 milligrams daily or rosuvastatin 5 to 10 milligrams daily. And many patients can tolerate statins using that approach. If we go to the next slide, Hannah, there's perhaps a simplified way of thinking about statin intolerance management, that it's certainly worth trying with a lower dose of high intensity statin. You can try repetitive re-challenge, de-challenge. We know that rosuvastatin and atorvastatin have long half-lives, so you don't necessarily need to give them every day. And it is often very useful, I think in my practice, to try weekly or twice weekly treatment with a lower dose of rosuva and atorvastatin. And patients who are historically statin intolerant can often tolerate this, and then can be encouraged to gradually step up the frequency and dosing over time. And just a note at the top left there that adding ezetimibe to a lower dose statin can be very similar to giving a higher dose of high intensity statin. So it's worth considering low dose atorvastatin or rosuvastatin with ezetimibe, which can give quite potent LDL lowering. Next slide, please. Again, another underused and underprescribed adjunct we have to lipid lowering, which has been available recently in the UK following NICE technology appraisal, is icosapent ethyl. So over the years, we've had a lot of discussion about whether omega-3 fatty acids are useful in patients with cardiovascular disease. So icosapent ethyl is slightly different to the types of omega-3 fatty acids that have been used previously in clinical practice, and very different to those that are available over the counter. So this is a very highly purified form of omega-3 fatty acids, and it was shown in clinical trial, we'll show you the data in a moment, to have significant reduction in cardiovascular events in patients with CVD or at high risk of CVD. So the licensing is at the top there, so it's basically in patients with high cardiovascular risk and triglycerides above 1.7 millimoles per litre. And we'll see at the bottom the NICE technology appraisal, which basically limits the use of Vascepa to patients, secondary prevention, so patients with coronary heart disease, stroke or PAD, patients with well-controlled LDL cholesterol. So this is an add-in once the patients are on statins plus ezetimibe, have an LDL cholesterol between 1 and 2.6 millimoles per litre, and with a triglycerides of 1.7 millimoles per litre. Now, if we go on to the next slide, we can see the clinical benefits of adding in icosapent ethyl. So these, you know, really, these are really quite persuasive data when we take into account these are patients that were already well treated in terms of LDL levels. And you can see that adding in icosapent ethyl for the primary endpoint shown on the left here led to a significant risk reduction and quite a substantial absolute risk reduction, with a number needed to treat of only 21. It's worth bearing in mind that the mechanism of action is probably not through triglyceride lowering. So the actual effect on triglyceride levels with icosapent ethyl is modest, and it's likely that it has a number of other effects, particularly on cell membranes, and a mild sort of anti-clotting effect. So it has a slight increased risk in bleeding, particularly in patients who are treated with antiplatelets or anticoagulants. And the other potential side effect to remember is that there was a modest increase in atrial fibrillation in the REDUCE-IT trial. So it doesn't necessarily preclude use in patients with previous atrial fibrillation, but it's just something to bear in mind. Next slide. So I think, you know, Hannah's already covered this pathway that we need to think about in patients who have type 2 diabetes. Do they have established CVD, or are they at high risk? And do they have chronic heart failure or chronic kidney disease? And really, in patients like this who are at high risk of CVD or who have established atherosclerotic cardiovascular disease, then we need this introduction sequentially of metformin followed by SGLT2 inhibitors. So that's independent of HbA1c control. And, you know, really important to identify these patients with established CVD, heart failure, or CKD who would benefit from SGLT2 inhibitors. Hannah's already covered GLP-1 receptor agonists. You know, the availability of injectable GLP-1 receptor agonists has been troublesome over the last year. Hopefully that will change during the course of this year. NICE doesn't position them highly, majorly because of cost effectiveness. But, you know, in terms of clinical effectiveness, they're really useful and you know, very good benefits in terms of cardiovascular risk reduction, and can be coupled with SGLT2 inhibitors. Next slide, please, Hannah. So, yeah, I can't remember, Hannah, am I covering this or are you? I'm happy to carry on.
I think I probably already covered it, Steve, to be honest.
Yeah.
I think, yeah, in my previous slide, so I'll just skip over that because I think I took a bit of time on that anyway. So this is me. So when we're thinking about chronic kidney disease, obviously we need to think about what stages of chronic kidney disease somebody has, and you can see here is the classic KDIGO heat map here, and the colour coordination is not about renal risk, but actually is about cardiovascular risk in these in people. So if somebody is, for example, very albuminuric but might have a normal EGFR, they could still be at significant cardiovascular risk. And albuminuria is our canary in the coal mine, so it's our early warning marker that something's about to go wrong on a vascular level in general. So if something's going wrong with your kidneys, it gives you a bit of a heads up that things are about to go south with a number of things, and that's why that cardiovascular risk factor management at that point is so very important. Just to highlight as well, the Kidney Research UK have just put out a health economic analysis of kidney disease. This is a really interesting read if you've got a few extra hours on your time, but it is fascinating. It's quite a bulky document, but you could just read the summary documents. But it really is fascinating to see that actually really where we make a lot of savings with renal disease, financially, it's obviously a huge economic burden. Kidney disease, if it gets so far down the line. And so what we're trying to do is just prevent at every stage of the way. And one of the things that saves the most money actually to our healthcare system is making sure that people are on transplant lists. So this is something, again, that we can ask people about. Are they willing to be an organ donor? Obviously, can be significant problems actually with getting people on organ donation lists from ethnically diverse populations. So again, something really important to mention and to see whether people would be willing to go on registries as well. So so a really interesting read if you want to update on all things renal related and the cost to our healthcare systems. And as we know, doing our basic care well is really, really important. And for the past 18 years, RAS blockade has been the only licensed treatment shown to reduce renal events in patients with type 2 diabetes until we got the SGLT2s, and now we've got finerenone, which we'll talk about in a little bit more detail. So for a long time, this is really all we've had to offer people. And yet we still manage to not sometimes do this standard of care well. We'll see a lot of people with renal disease on non-ACE or ARB therapies for their blood pressure, and really we should be switching or adding in an ACE or an ARB to already established therapies. And remember, if somebody's already got renal disease, and you'll see in the West Yorkshire guidance based on expert opinion, and we've actually gone with the KDIGO guidelines around much tighter blood pressure control than NICE guidance for people who have significantly developed renal disease. DAPA-CKD, this patient's on dapagliflozin, so there's also an empagliflozin has changed its license now, but I'm just presenting this today in the interest of time. As you can see again, as Steve showed with some of his data, really compelling data around this primary composite outcome, which was around a sustained decline in the estimated eGFR of at least 50%, and people progressing to end-stage kidney disease or any death that associated with renal or cardiovascular causes, and that's the key as well. This occurred, as you can see, massive, almost very quick deviation as well. You can see with the Kaplan-Meier curve. So very early on, we see the benefits of these medications from starting them, and that's really why it's important to get in with this therapy as soon as you possibly can. It's already making a difference from people right from the get-go. And this is a really nice guidance. This is one of the KDIGO slides, and again really hammers home the importance of lifestyle underpinning everything that we do. Healthy diet, physical activity, smoking cessation. If somebody smokes, you could go to the far ends of forever to add in all these different drugs, and really you're going to struggle with reducing cardiovascular risk beyond what you could do with smoking cessation. Smoking cessation is a fundamental to making sure that we've nipped cardiovascular risk in the bud. And again, weight management, thinking about weight management more regularly. We have a commissioned NHS weight management programme that we should be referring a lot more people to than we are. It's commissioned, it's paid for, and we're not using it. And it's really, really important that we try to refer people who might want that support around losing weight, in addition to obviously being able to be referred for drug therapy as well. And as we said, that first line drug therapy, and this is for people with diabetes, so SGLT2 and metformin. GLP-1s do have evidence base in renal disease, actually. They have evidence base mostly around people who are already what we call overtly albuminuric, where your urine ACR has gone over 30. And so again, these are good drugs, and they should be added in sooner rather than later if you can, and if people are eligible. And again, we're thinking about optimizing your RAS blockade, and also now thinking about adding in things such as a non-steroidal MRA. And again, the lipid therapy, as Steve's already taken us through. So what is finerenone? So finerenone is a non-steroidal MRA. So it's like spironolactone, but because it's non-steroidal, you don't get any of the gynecomastia symptoms that you might get with the spironolactone. And clinical trials have demonstrated that this drug's beneficial in kidney and cardiovascular prevention on top of RAS blockade, basically. So And experimental evidence suggests that RAS blockade leads to actually incomplete suppression of these serum aldosterone levels. So something called the aldosterone escape phenomenon. And this offers this opportunity then to consider this MRA alongside of this treatment to optimize the residual albuminuria and to ameliorate any sort of kidney fibrosis that you might get. Okay, so again, it does reduce albuminuria. However, their effects on kidney disease progression haven't been examined in larger trials. So we just need to be aware of that. It does increase the risk of hyperkalemia, and this is the bit that everybody's going to get a bit nervous about. And so we need to work with the guidance that's been given. It's very robust. The summary of product characteristics is very robust. At the moment, we've got it on specialist initiation, just to gain some experience of it, and then hopefully that will change over time as we as a system understand how exactly hyperkalemia comes about, and we can then work together again through this through these tiered models of care to make sure that everybody feels supported in the use of these drugs at the point where we need to use them. Two big trials around finerenone is Fidelio-DKD and Figaro-DKD, and this is looking at slightly different cohorts across the board. But in general, these two trials have shown excellent results. And when initiating finerenone, we need to consider where are we starting at with serum potassium levels. Clearly, if you've already got a high potassium, adding in something that's going to raise your potassium is not going to be a great idea. And they've given some reasonably useful targets about what you need to do. So again, around if it's over 5, we wouldn't start. And again, around serum potassium levels can be started if it's less than 4.8 and you've got the your EGFR is between 25 and 60. Okay, and you start at 10 milligrams and it can be titrated. And then your continuing dose again depends on where you land with your potassium 4 weeks after you've started it. So and at this point you can basically carry on and titrate, or you can maintain, or you might withhold treatment and then reinitiate thereafter. And again, you then afterwards you're going to think about measuring serum potassium, usually based on patient characteristics and the serum potassium level. So the idea is that unless something changes dramatically with that person, once you've gone through this process, they should be fine with their potassium. There wouldn't be anything that would normally rock the boat with that. But obviously, if anybody came in symptomatic of high potassium, we would want to obviously do Usenis and make sure that they were okay. And there's limited data with finerenone below an EGFR of 15, so we wouldn't use in that cohort. And obviously, there are other things that we need to consider if our renal function has declined beyond a certain point. We need to think about other therapies. Often I do see that people forget to change the dosing of metformin when somebody's renal function has declined. And again, this is a really useful algorithm around how we manage renal dysfunction with metformin, and also around kind of other monitoring. So for example, B12 deficiency needs to get looked at as we would with metformin now anyway, and the MHRA guidance around that. So this is a really useful thing that you can find in the KDIGO guidelines. And we're going to skip over this one because I've got a feeling that we're running out of time, and we probably did want to leave some time for some questions. So we'll pause and take any questions. Thanks for listening. Just reading the chat. Yeah, great. Okay, James, I see a question about the remission program. So it's normal for them, not not normal as in the standard diet. So I think that, you know, the remission program is very detailed, and they do have quite a lot of detail on different diets and different cohorts of populations as well. So they would tailor their advice. It is personalized advice that they get during the period of the remission program. So normally we would say that it would be appropriate for people of low socioeconomic backgrounds. In fact, you probably find larger cohorts that might be suitable for the remission program within lower socioeconomic groups, actually. And I think that, you know, sometimes it can be a lesser of burden because they're getting rid of all their drugs, and not just for diabetes but also for lipids, etc. So it can be more helpful because people tend to be working or have more complexity to life in general. So actually, I think it is a really important thing that we mustn't rule out for people within those populations. Actually, I hope that answers the question, James. Somebody was going to ask about ICOS pentethyl. Feel free to put up your hand and speak to us, by the way. We're happy to take non-chat. We've stunned everybody into silence, Steve. We've clearly done such an excellent job. Janet. Janet, do you want to ask your question? Don't know whether you're on mute. Can't hear you.
Can you hear me?
Yes, perfect. Thank you.
Okay. Yes, I had a bit of a question about that ICOS event. Don't use it an awful lot, but we do have one patient on it for the high trigs. My concern, or his concern as well, is I think been on it for 8 months. And like Stephen said, you're not necessarily going to drop the trigs by a lot with it. And he's like wondering, like, why am I taking this? And especially because our patients like to see figures, because he's taken other treatment as well for lipid therapy. So what language do you use when you're talking to your patients about the ICOS event?
I think that's it's a really good question. I mean, so when I'm talking to patients, I emphasize that triglycerides are just used as a risk marker. So, you know, we've got really good epidemiological data that show that over and above LDL cholesterol levels, then raised triglycerides are associated with an increased risk of cardiovascular events. So I think we use the trigs as a marker of increased risk, but I point out that we're not expecting the icosapent ethyl to reduce the trigs significantly. So the mechanisms are just not through triglyceride reduction. They're probably through multiple other effects on cell membranes, endothelial dysfunction, effects on plaque progression. You know, there's some data showing that they can affect plaque progression. So I think it's just that messaging that we're only using the trigs as a sort of marker determining who may benefit, but that we're not expecting trigs themselves to decrease. But you know, the benefits in terms of reducing risk in the trial were real and quite persuasive.
Thank you for that.
Any other questions?
Perfect. Okay, great. Well, if anybody thinks of anything in the meanwhile, you can pop anything into the chat. But otherwise, we'll thank everybody for attending, and thanks for giving us the opportunity to come and speak today. So it's been a pleasure.
Yep. Just to reiterate that, Hannah, thank you for everyone for coming. Thanks to Health Innovation Yorkshire and Humber for hosting this webinar.